Hey folks, Scott Weingart here, and this is an EMCrit podcast. Today on the podcast, we're going to do procedural sedation part 4. We've had 3 previous iterations on this, and today part 4 is on the critically ill patient, and we're going to be discussing a new regimen called MidaKet with my partner in crime, Josh Farkas, later on in the show. But let's talk about what the context of this is. So, in general, most of the procedural sedations we do in the emergency department are on relatively healthy patients. Patient has a shoulder out, some kind of joint reduction, or we're cardioverting a patient who is not moribund. We are doing most of this with the consideration only of avoidance of things like respiratory depression because the patient's doing okay otherwise before we actually gave the procedural sedation. But there are going to be patients who are super sick and yet still need some form of a sedation for a procedure. And so that's what we're going to be talking about today. Now, can we even do this in an emergency department or an ICU? Well, let's deal with the former. Most of the time in most departments, they'll do American Society of Anesthesia, ASA class 1 or 2 people. And these are people who are either healthy or they have mild disease that's not really contributing to a significant threat to life or particularly severe. And then 3s and 4s are supposed to go to the operating room. Now, first of all, that just doesn't happen in most hospitals. The anesthesia schedule is so tight that even if you wanted to, it would be really tough to get these patients in. And then, I don't think it's necessarily for many of these super sick patients the best move to have to transport to an OR and back. You're probably going to want to do it in situ, wherever the patient actually is, with the ability to manage all of their shock state, hemodynamics, respiratory tenuousness, all of that where they actually are. So Jim Miner did a study sometime in the early 2000s on ASA category 3 and 4 patients in the ED. And so just, as context for anyone outside the United States, ASA 4 is a patient whose disease state puts them at threat to life. So these are like really sick patients. And 5 is like the patient's not expected to survive whether you do a procedure or not. So 4 is basically the sickest patients that you really would be considering what to do with them. And these patients did fine in this prospective observational trial. Not perfect evidence, but pretty good that you can do 3s and 4s in the ED. And by extension, I think you could do them in an ICU as well. And in some ways, you have a lot of advantages because you have all of the bevy of medications, auxiliary treatments, and mechanical support devices like ventilators that you would need to manage these patients after the procedural sedation is over. They're still going to be just as sick. So I think it makes a lot of sense to just start with the mindset that these patients should just be done in whichever critical care unit, whether it be the ED or the ICU they're in. So now, what to use? Well, if it's purely anxiolysis, then I think midazolam is your med of choice. Now, I have taken, early on in my career, I would do awake patient central lines, for instance. We were doing a lot more central lines back then than we are now. And we'd have these sick patients. They'd need to go on pressors. The idea of peripheral pressors hadn't really come to the fore yet. And we would be just saying, all right, just chill out. We're going to cover your full head and body with this drape, and we're going to stick needles in your neck. And it didn't even occur to me that maybe there was a better way. And the better way that I eventually developed is give them a small dose of midazolam. Just do it for all of your awake procedures where there's any degree of associated fear or significant discomfort. Just give them a little midazolam. Even if you're going to do local, obviously you're going to do local. I hope you're doing local. I've seen people do radial art lines in completely conscious patients without giving any local, and that's just mean. Don't do that. It hurts a lot. You don't need midazolam for a radial art line, but if I was doing a femoral art line, I'd probably consider it. It just makes everything nicer. They like you. You like the state they're in. It takes off some of the anxiety. You get amnesia, and therefore they no longer are going to remember any, additional sticks you might have taken during that procedure. It's just good all around. Now, the one caveat I'd put there is if you have a strong inkling the patient's going to be needing consent for important things, I would really get those consents up front before you gave them midazolam, which doesn't mean you can't consent the patient afterwards, but it puts you in a slightly more gray zone. So I love the idea in critical care units of getting blanket consents signed up front, by which I mean not one consent that says we can do whatever we want. But at Shock Trauma, we had a standardized unit consent form that would have all of the standard ICU procedures. So central lines, radial art lines, discussion of if you needed blood, what would you want, lumbar puncture, etc. Doing all that up front so that when these things need to get done, you don't now have to call a family member at 2 o'clock in the morning. Okay, we're going off topic. I'm sorry. So midazolam for anxiolysis. Dexmedetomidine is nice, and I did an entire podcast on dexmedetomidine, so I'm not going to belabor it here. Dexmedetomidine is very nice for things where you don't require a patient to be truly out. So you're not going to get deep sedation. You're going to get this sleepy state. You're going to get some degree of analgesia, or at least synergy with the patient's existing analgesic regimen. And, oh God, the pharma folks are going to kill me. I don't know. It's not synergy. You're going to get a opioid-sparing effect. I'm sure it's not synergistic. We'll hear about that later on when we talk to Josh about MidaKet. But dexmedetomidine is a great way to go for procedures that don't require the patient to be truly out. So can you use dexmedetomidine in a critically ill patient? Yeah, as long as you don't give the bolus and you start low and work your way up, you're probably going to be pretty safe from a hemodynamic standpoint, and you're not going to get really any respiratory depression. So yes, you can use it. It's not going to take you through super painful procedures, and it's not going to get you muscle relaxation. So it's for things for me, like I'm doing a pigtail on a patient that's, a little bit nervous. They're really leery. They don't want it. Even a chest tube, as long as you give plenty of local. With dexmedetomidine in the background, really, really nice way to go. Lumbar puncture, also. If the patient's like, no, I'm so scared of this, I don't know if I can handle it. Dexmedetomidine, I would always give those patients at least midazolam, but if the midazolam, doesn't strike you as this is enough for this patient, then going further with dexmedetomidine could be a really nice way to go. And it's relatively stable from the hemodynamic perspective, as mentioned, and the respiratory-wise, you're going to be safe. But what about when you need more? What about when you really need a patient out? Now, in the minor study, they were using propofol and etomidate, and the patients seemed to do okay. All of the propofol patients, all of the patients who got hypotension were in the propofol group. Etomidate was more stable. Only one patient had hypotension there. I don't think this is the best way to go. Can you do it? Yes. I think most of the vasodilatory effects of propofol, for instance, if you have a patient on vasopressors, kind of disappear. But it just doesn't seem the most clever way on an already tenuous patient to give them agents that both cause respiratory depression and potential hemodynamic perturbation in the case of propofol. So for me, the medication of choice was always ketamine. And you don't get as much muscle relaxation as you would with something like propofol. So if I had a really difficult joint reduction like a hip, I might have to add some propofol to my ketamine. But ketamine alone was what I was doing for most of these patients. Now, I would always give the critically ill patients a little bit of midazolam with their ketamine because I just didn't want to deal with a critically ill patient having to emerge and have any issues at all. It's nice and clean. You give them a modicum, a tiny bit, 1-2 milligrams of midazolam. And most of the time they emerge much more cleanly. They don't remember their hallucinations. But then my buddy Josh Farkas, partner in all things EMCrit, did a post on MidaKet, a combination of a higher dose of midazolam with the ketamine. And we're going to do a little interview now about why he thinks that's a better way to go. And he's kind of convinced me. So we'll see what you think after the interview. And then I'll join you back again solo to talk about some closing thoughts. All right, let's go to Josh Farkas, brilliant pulmonary intensivist, editor-in-chief of EMCrit, and partner in all things EMCrit. Let's do it. How are you, Josh?
I'm good. How are you?
I am excellent. Now, I saw a post you put up, and I'm like, I have to get you on because I want to talk about this. I love it. It's called MidaKet for, what would you call it? Unstable procedural sedation? What's your overarching category here?
Yeah, I think just procedural sedation for critically ill patients, which is an interesting, potentially niche topic and something that I think we could talk about more just in general.
Yeah, I love it. So my first question to you is, why not ketazolam?
I thought about that, but I feel like you start with midazolam and then you give ketamine. MidaKet made more pedagogical sense to me.
All right, that's a perfect answer. All right, why don't you briefly tell people what this actually entails, and then we'll go into some intricacies.
I have to be honest. I started using ketamine monotherapy several years ago. There was a lot of interest in this in the emergency and critical care literature. as hemodynamically stable, doesn't suppress respiratory drive, has a lot of great potential. But the reality of using ketamine monotherapy for sedation, pretty disappointing. Some patients have pretty negative responses to it. I was surprised to encounter this phenomenon of ketamine resistance, which I blogged about in the past, which is that there are some patients, especially alcoholic patients or patients who have been exposed to recreational ketamine, who just never respond to ketamine, or you need to use insanely high doses of ketamine that cause those patients to just subsequently be like in this ketamine-induced haze for hours. It can cause MS. And I did actually encounter laryngospasm twice. So it wasn't quite as beautiful as I feel like it was billed, and I stopped using it for a while. But there is definitely a group of patients where you want to use the most hemodynamically stable, respiratory stable agent possible. And I slowly emigrated back to this concept of MidaKet, which is where you start with a moderately sedating dose of midazolam. So basically, you're giving titrated dose of midazolam. You try to get the patient kind of, I'd say, mildly obtunded, somewhat drunk, and then you give small, moderate, like 25 to 50 milligram doses of ketamine to get you to the point of procedural sedation.
Yeah, I love it. And so I love ketamine monotherapy when I don't mind if the patient's going to take a trip. And when I have the ability to prep them for that trip and make an assessment of where their psychological openness to that is. For everyone else, and that for me is kids and old people, I would always be giving at least a modicum of midazolam. And for me, putting critically ill patients in that same category makes natural sense because they got enough things on their plate. I don't need them flipping out from what is, in essence, an angel dust trip. So I would always give them probably a 2 milligram dose of midazolam routinely. But after reading your post, I'm feeling that I should move towards higher doses of midazolam. And I hear the ketamine sparing effect. That is a beautiful effect. Some things in your post I had never come across. Like, for instance, it has an anti-sialagogue effect by, I guess not a true anti-sialagogue effect, but it has a salivation sparing effect on the ketamine. Talk to me a little about that, Josh.
There was one study that suggested it might reduce salivary secretions. I don't see that as like the selling point, but it is one potential benefit. One additional question is someone on Twitter did suggest if you really want to be super elegant, you could add in like a glycopyrrolate or an atropine is the anti-sialog. And personally, I don't think you need to do that. My experience with combining like glycopyrrolate or atropine plus ketamine is patients tend to get tachycardic and hypertensive.
Yeah, 100%. And my guess is, and I think you might be on the same page based on the lukewarm effect of this you actually feel it has, is we know salivation is a dose-dependent response of ketamine. So if you're giving MidaKet and it is reducing your overall dose of ketamine, that might be in and of itself the only effect it actually has is just less ketamine equals less salivation. All right, what are some other salutary benefits to the midazolam added to the ketamine?
So I think it can essentially prevent a lot of potential problems with ketamine. So first of all, the patient is going to get antegrade amnesia. So if they had some sort of bad acid trip or scary dreams, they will not remember them, which is great because every once in a while we do encounter these patients who have a bad trip and then they get this label as like a ketamine allergy, and that can be problematic if you want to use ketamine as an analgesic, et cetera. Subsequently, it can reduce the ketamine dose, which I think can help us decrease a lot of ketamine side effects like emesis potentially and prolonged sedation due to ketamine. It can avoid this kind of recreational dose or sub-dissociative dose. So I think when you give pure ketamine, you end up oftentimes in this like bad area where the patient is not really sedated, they're not awake, they can be a little bit agitated, and they're not going to remember that necessarily, but that's not great. And my experience has just been like you can use smaller doses of ketamine